Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
Hi, we are back today. I'm very excited about today's episode. We have Dr. Natalia Khosla, who is, so amazing. There is so much I can talk to about her. I'm going to give a brief bio, and then I'll let you describe, everything that you're doing now. But she is, of course, a physician. She is Yale educated, an undergrad, and she went to University of Chicago for medical school, and did all sorts of amazing things, like being a Fulbright scholar, and of course, just an absolute genius. But on top of that, she is the CEO and co-founder of Simbie AI, which is a Y Combinator-backed AI voice agent platform, automates for medical practices. That she could tell us a lot, more about that. But what I love about Dr. Khosla, and we've talked to her about this, is that I think what we share is this advocacy for physician-led development of health technology, which, we could go really deep about that, but I'm really excited to speak to that and why that's needed so much in this world of just, really corporate medicine, doctors being burnt out, patients also not being super happy with the way things go. So a lot to kind of unpack there, but welcome. Thank you for joining us.
Thank you so much. Thank you so much, Dr. Kamangar. It's totally an honor to be here, actually, because, we first met at AAD in March. And before that, I had sort of been a fan from a distance of you for a while via following your podcast. So it feels really full circle, and I'm so excited to be here.
Oh my gosh, thank you for listening to the podcast. That's amazing. And it was so great meeting you at the AED, because you were just the nicest. I'll say that first impression of you. You come up and you're just like the nicest person, and obviously like extremely intelligent and so humble. And then you start telling me about your AI product and how you've been through Y Combinator and what stage it's at. And I'm like, oh my God, you are like a highly successful CEO on top of being a physician and an MD. And I think that's something I love about female entrepreneurs and female leaders. And that's a shared trait I've seen: highly effective, but yet humble enough to make the product better and better, and just like network and meet the people that need it to make it, take it to the next stage. So, and I think that's another thing we share is female entrepreneurship. It has its own different flavor of success to it. So it was such a pleasure meeting and connecting. But yeah, tell us more. You're doing so much. And actually, I don't know if I mentioned this, but you're also then now will be applying to dermatology residency, which is also amazing, because with all the success you have, everything you're doing, you're still just going back to healthcare and delivering care, which physicians at the end of the day just like to do. So if there's any residency directors listening to this, by the way, they're going to grab you up. So that's amazing. You're going to have a great journey with that. But yeah, I'll let you take it away. Let us know everything that you're doing.
Yeah, thank you so much, Dr. Kamangar. And I think I felt exactly the same when we met at AAD, because I think that, we'll dive into it a ton here, and we've connected about this a ton, but meeting another physician, especially dermatologist, who is sort of entrepreneurship forward, innovation forward, and actually forging innovation, building themselves, is something that I feel extremely passionately about. And when you meet another person doing that same thing, right, it's a small community of us, but I'm excited to help make it grow. And that's really one of my goals and kind of areas of major interest within medicine, medical education, and also physician advocacy and leadership, which is kind of, top of mind for me, especially in my role at Simbie, as I went through Y Combinator and kind of, in medicine too. So I so appreciate your kind intro. In terms of what we're doing today. So like you mentioned, during medical school at the University of Chicago, I actually started, I would come back from clinic every day with, like many of med students do, with scribbled notes on the side of my clipboard from my rotations, whether I was on rounds or in clinic, and just with all these ideas that were basically what I now identify as point of care problem identification and leading to potential solutions. At the time, all I knew them as was I wrote some notes on what if we did it like this? What if we did it like that? On everything from, can we have residents have, iPads where all the notes they're taking from running the list or from patient care every day are actually gathered somewhere, because we would do them on paper and then throw those pieces of paper away. And it's actually extremely valuable data that we were just tossing out every day, and obviously rewriting it. everything from that to, can we add more touch points with patients after visits, call them a few times using AI to review their medications, et cetera, which is actually part of what we do today. So I started the company really as just an idea in med school, ended up connecting with my co-founder and actually best friend and roommate from Yale for undergrad. We put our heads together and said, what if we built out some of these things? And so what we do today, Simbie AI, we build AI voice agents. So they're generative AI agents that use large language models to essentially enable their human-like speaking, and then voice synthesizers to enable human-like tone. And they're able to automate a number of tasks as if they're your medical staff in a medical practice. Everything from answering all your phone calls 24/7 in multiple languages at your front desk, to calling patients for you, to report biopsy results, review patient education, and much more. And so we went through Y Combinator, like you mentioned, after medical school, which has been an interesting, I've had a lot of med students reach out to me now about taking alternate paths in medicine, which I also feel very passionately about. But yeah, today I am the CEO and co-founder of Simbie, and, run that as I kind of continue with my interests in medicine, dermatology, and research. But it's been one of the most fulfilling things sort of to do.
Oh my gosh, amazing. It's been such an amazing journey that you've taken, and you've done it, in a compact way. It's not easy to have medical school curriculum to complete and then also develop these ideas. But I love, all of the things that you just said. I mean, it really starts with point of care problems. And I think that's the main thing that physicians, need to realize. And then I think you had a post actually on LinkedIn, and I love your LinkedIn posts. I always read them.
Thank you.
I think you had a post about this where physicians almost need to be the complete master of something before they embark in it.
Yes.
Whereas other people in other fields don't need to, reach that level of competency before they go for it. And the thing you mentioned is that physicians you're already there. You know so much more than anyone else. And it's that point of care, finding out what actual problems there are. Because historically, a lot of the fear of technology in healthcare, like the EMR burnout and the clicks and all of that, has been technology development, but not with the physicians in the room in the first place. So the only way, to me, it actually makes sense, and exactly what you said, it needs to start from, hey, here's the problem. Let's work backwards to figure out the technology that fixes it, versus here's some technology, make it work and figure out, what market fit there is and what problem it solves. So exactly. You just nailed it. And I'm sure every med student, every physician, every attending has a million of those every day where you're like, this is a pain in the butt. And that's really it doesn't have to be some high level thinking. If you have a moment where you have a task and you're like, this is hurting me on some level, that's it. That's the problem.
Yes, exactly.
that you need to fix.
Yes. It's exactly to your point. I actually think now, looking back on it, so in the startup world and when we, and you know very well as a founder, and something we think about a lot is, in agile methodology or an iterative startup methodology is, the problem space is the most important space. The solution will change, should be expected to change. If you are being agile, should change a lot, right? Your product should change a lot. It should evolve and respond to new technology. There's literally a new voice AI model coming out essentially every 4 days right now. So we have to be agile. So the solution will change, but the problem and a deep understanding of the problem, that is actually what companies spend millions and millions and billions of dollars to find people who actually understand the point of care problem. And I think I didn't realize in medical school how valuable that knowledge was, right? I obviously you're seeing things kind of fresh with this nascent sort of eye as a medical student. And now looking back, medical students might be some of the most well-positioned people to start healthcare technologies, because not only are they not sort of jaded by having used things for a long time, but they have that nascent mindset. But they're really able to identify problem spaces themselves. And I think, as a founder, I feel very strongly about spending most of one's time in the problem space and then letting the solution kind of roll out of that. To your point, I think I can't tell you how many times today I am in rooms where there are people deciding technology that's going to be built, and there are no physicians in the room. And this is healthcare technology where the end user is physicians and patients. And so it's wild to me that we don't have physicians in the room. I do think there are a lot of reasons that contribute to it that we'll dive into and that I think we can make changes on. But the outcome of that is what we've seen, right? Tone deaf technology that, and even beyond technology, health systems. When you have leadership that's not physicians, you have technology and initiatives or decisions being made that are so removed from the point of care practice of medicine that their P&L sheet, profit loss sheet might show, oh, wow, we just saved a lot of money or we just increased throughput. But the invisible metric that never gets found is, okay, well, you just, spurred it provider burnout in 20% of the department, and now people are planning to retire early. And I think these types of decisions are why it's so critical that we have physicians at the helm of innovation in systems or in technology development.
Yeah, and I agree with I'm nodding my head because I agree with everything that you're saying. So I'm going to date myself because I'm old, but I started working because I did a background in engineering, but I went to med school, obviously, because then we're here where we are now. So during med school, I started doing a lot of work with kind of tech companies, kind of at the intern level. These opportunities back then were not as open. There just wasn't as much excitement around health technology. Like I would mention things to my attendings on rounds and they were not having it. Like it just wasn't quite, as hot then. But I find it was the same problems of then exist still today. So it's so amazing to me that you're mentioning like your generation is starting to really change this and change this paradigm of you're looking around these meetings and there's no physicians, whether that is a technology innovation type of meeting or worse, a leadership level meeting, because leadership is so important. And you see that that's dwindled less and less. It's a lot of business people leading, medicine now. So it's a problem for sure.
Absolutely. I think it really is. And, when I think about, I've thought a lot about sort of what it is that we can do to change this trend, because we've really seen this as a trend. Like, I quote this stat all the time. I'm pretty sure I wrote this in that LinkedIn post, but today, fewer than 5% of CEOs of major health systems, for example, are physicians. And I find that to be a pretty jarring statistic, right? I find it to be pretty disturbing because at the same time as we've seen that number decline, we can see very clearly in healthcare, almost mirroring that exactly, that we've seen a corporatization of the field. And I really don't mean this to say anything against non-physician or non-clinician leaders. Like, I think that the people doing this work are very well-intentioned and they really care about patients and about outcomes. The problem is it is almost inconceivable, right? That someone who's spent, like a physician, right, thousands of hours, literally. I sometimes want to visualize it to people, like what medical training entails. Thousands of hours in a room with a patient, holding their hand, talking to them. You know their story. You know where they live, what they eat. You know their bowel habits. You know their sister, their mother. You know their story and what they're going through on a level that you can never match with a data sheet, which is what patients become when you're looking in boardrooms, right? And
Yes.
even in technology innovation, if you're looking at, how do we build XYZ tool, and you're just looking at, okay, well, what we're trying to do is increase, let's say, take a metric like, patient satisfaction, or we're looking to, improve hospital bed stays in the hospital, and you just see it as a metric, but you don't see how on the ground, what are the real reasons? What are the patient's emotions, their interaction with the staff, their interaction with their family that are causing them to need to stay an extra day? How can we make changes on that level is going to be very different than making sort of high level changes. And I guess just to touch on the point to the end of, medical students and physicians at the point of care being some of the most valuable problem identifiers. I'll tell you today, now in my role, the number of founders around me in health tech who are non-clinical, they don't come from a clinical background, who basically come to you saying, we have this technology. What's the use case or problem we can fit it into? That is the most common dilemma that technologists have, is they've built technology, they don't know what to plug it into, right? And that is where you get terrible tech, I think. If you have solution first, plug it into a problem, that's how you get kind of EMRs, where essentially they're billing systems, but we've tried to plug them in as clinical solutions, and that's why they don't really match physicians' workflows at all.
Yeah, no, I agree with all of that as well. And one of the things I really saw in a lot of the meetings I had with like administrators as chair of our department, things like that, was as the clinician, I was almost just doing the clinical correlation to the P&L. There's the numbers, and then you have to do that clinical correlation, and that point of care, point of view is so important. So for anyone out there who, let's say, has an idea right now and has kind of identified a point of care issue. So tell us about so Y Combinator. A lot of people might not even know what that is. If you want to talk a little bit about, so it's a type of incubator, and there's other ones, but tell us a little bit about what a program like that could offer to a physician. Because I think tech people kind of know these things well. You go in there and you know what kind of resources are given to you and if it's worth it or not. But as a physician, you're going into a program like this. Like, what kind of mentorship does it offer? And is that the kind of right setting, or are there different types of incubators that physicians should look at for the extra support to build out an idea?
No, it's a great question. So I think, I'm excited to, with leaders like you, build a future in medicine that really makes these resources immediately accessible and brings them into just sort of to the attention of medical trainees or physicians. Which I think we'll have in the future. And I think that's growing right now. In terms of what I'd suggest to people and recommend. So yeah, Y Combinator is what we did. It is a incubator, like you said, in based out of the Bay Area, sort of produced out of Silicon Valley. And I can't sort of speak more positively about our Y Combinator experience and how important it was for me. I'm not someone with a business background. I'm not someone with a technology background. I went into entrepreneurship saying, I am a physician and I know the problems. I know what I saw is breaking, and I know how it's hurting my physician colleagues, and I definitely see how it's hurting patients. I think sometimes you can see how technologists have an eye towards things like, let's improve patient intake, for example, but then when we went into it in Simbie AI, what I brought to my team was, hey, specifically, there's this thing called medication reconciliation. It's taking up, when I saw in clinic, sometimes 40% of the visit is spent on medication reconciliation. What meds are you taking? Which tubes? Which creams? How many times a day? Which one did you stop? Why? Do you know the names of them? That is something that can be gathered in advance to improve the actual in-clinic experience. Is an example of something where if you're actually there, you can give more kind of specific ideas of the problem. So I would say the value of Y Combinator for me was, okay, you know the problem. Now let us give you the ropes on how you turn this, how you interact with the startup community, first of all, how you meet the right people, and how you turn your idea into MVP, minimum viable product, and then how you turn that into execution, iteration, testing, iteration, which ends up being the rest of the startup journey is testing and iteration. So I would say that I would definitely recommend some of these incubator and accelerator programs. Techstars is another one that's well known. And now I've been excited to see there are a number of others that are actually affiliated with health systems, which this is one of my thoughts on how we should be doing innovation in the future for physicians and medical trainees, is because if you can actually have, in my future ideal world, there would be incubators actually in health systems and in academic medical centers. When I was at University of Chicago, I always thought, we on rounds and us, the medical students, physicians, and PAs, NPs, pharmacists, nurses, we are all working on these interdisciplinary teams. And all of us every day, I know, have ideas or identify problems of what could be better. If we could just have an interdisciplinary almost forum at the end of every month or something where people bring forth ideas, and ideally you would have some engineers there who can help you think through breaking down your problem into an engineering level execution nugget. And then ideally, if you even have investors there, you can actually generate, I think, the most relevant solutions right in the academic medical center. So that's what I think, what I hope is this one day. And I'm chatting with some really kind of forward-thinking folks at my medical alma mater at University of Chicago about things like this. But I think for now, we've seen some incubators actually be built out of health systems or out of even like insurance companies, which can connect founders who are physicians to the health systems that they could sell into, or allow them to test or iterate or pilot their products very immediately. Because I think that's one of the hardest things for an early founder is, how do you take your idea, your product, let's say you've built out an initial small version, how do you check if it's working, right? And that really requires getting into a system, putting it in the EMR often, trying it with their patients. And that can be a big barrier, I think, that slows and bottlenecks the process.
Yeah, no, I love that vision. Everybody in the same office, you have the engineer there. And it's true because
Yes.
sometimes a lot of the best ideas I get from my medical assistants or my nurse, because the workflow, some of the workflows they're even dealing with way more than even the physician is. You have this like whole staff physician, and even the pharmacists throw them in the mix too. And it's, this kind of health interoperability is definitely an issue. And you mentioned earlier, a medical student writes the notes and then they just toss it. And that's another whole barrier, is getting everything from fax and paper, just even into digitized form, so that we can, because people talk about AI, but I don't think they realize how far away we are from that, from a kind of health care standpoint, like a big structure, these big kind of healthcare system standpoint, because a lot of the data isn't even digitized yet for us to, apply
Oh yeah.
AI to it. So if you could just imagine all of that being in one place,
Oh
I mean,
yeah.
that,
Oh
that
yeah.
that is the dream. That is the dream.
That is definitely the dream. I mean, to your point, so with us, with Simbie, we go into practices, and obviously one of the first things we have to do when we onboard a new practice to our platform is, okay, well, what are your current workflows today? If we're going to automate your front desk, we have to understand, what is your process for one of the most complex processes I will tell you is scheduling. And you will know this well. Scheduling is maybe one of the most complex processes because, the various providers, the various visit types and
Yeah.
procedures they do, the various insurances each are accepting, that entire process. But then everything else. How do you do patient education? Do you want more touch points after the visit? Do you want us checking in on patients even up to every day with a AI phone call? Did you take the medication? Do you understand how to take it? And I think one of the most illuminating things for me doing this has been, if you ask providers and their practices today, whether you're talking about a, five provider, mom and pop style sort of healthcare provider practice, or a big health system. If you ask them today, what is your baseline? What is the percent of calls that your front desk staff are able to completely answer for a patient? What is your abandonment rate of patients hanging up because they're on hold too long? What is your rate of patient satisfaction with their education level when they leave visits? A lot of times the reality is practices actually don't know the answers to those questions.
Yeah, that's true, actually.
To your point, because there's so much happening in the system and so much of it is paper. And honestly, systems have grown at a faster rate than the technology has kept up. So most of their data is not being collected anywhere. And so usually the first thing we actually have to do is go in, and we do like a week or two of just recording all their phone calls and basically shadowing all their staff to gather. And we will go and tell them, it turns out, 30 to 40% of your phone calls are being sort of like handled inaccurately at the front desk. I mean, they may have
Yeah.
not even known that. Or it turns out you're using this sort of outdated patient after visit summary or handout that is not up to date with guidelines, and they might not even know that. So that audit that we do actually ends up being some of the value, to your point, because a lot of this data is not even being compiled today.
And you have a really good point, because I think people assume the way they're doing it is the correct way.
Yeah.
AI could potentially have error, but I don't think people realize the amount of human error that can happen. And for me, I practiced in large healthcare systems where sometimes our front desk people might change, like they might be out, maybe they send somebody over to dermatology from OBGYN. They don't know how to do dermatology scheduling. It's complicated. And then I think, this is great for the dermatology field that you're going into. And of course, you guys are probably doing this in all sorts of different offices. But dermatology specifically, we have such a huge problem of scheduling because we're a high volume type of specialty. There's not that many of us. So there's always these impacted schedules. And we see way more on a day than, internal medicine or any other one of our colleagues. We have way more, inpatient messages coming in, messages about scheduling, these telephone encounters that get created, like 6 encounters about the schedule. It is a
Absolutely.
huge problem that causes a lot of burnout. And if you can't get your schedule right, you can't get your business right. Like if you don't know who's coming in, at what rate, what percent is new patients, what patients referrals, what doctors referrals, or do you want to get in sooner? Like if you don't have a good handle of that, there's no way you're going to have a scalable business. So, I mean, just even that alone is such a huge pain point
I
for dermatologists.
totally agree with you. And, it's really interesting seeing the different specialties be on our platform. Definitely gives you an eye towards, to your point, that the pain points, and, that there's actually much more similar than different. And I guess one of my larger physician advocacy points around has been this, that I think our specialties have become so siloed off from each other that sometimes we see ourselves more as X specialist than physician, and physicians have more in common than different. And I actually think, to a separate point, that's what can help us with physician advocacy that I think is massively, massively lacking compared to other professionals who, for example, would not tolerate a lot of the sort of system flexibility that systems just expect of physicians, or the extent to which it's expected that physicians will sort of just keep taking on more and more and more by making these sort of moral guilt appeals to physicians when we can see burnout is at massive levels. But I think to that end, physician similarity is high, but the differences between specialties are also quite apparent. So like we have just onboarded a few of our dermatology practices onto the platform, which has been exciting. I think it's a really great use case for this technology because, like you said, one exciting thing in derm that I love is that a lot of it is still community-based practices. A lot of it is still independent practices. And I actually think it's on the back of independent physician-owned medicine that some of them not only highest quality patient care happens, which we know, statistically, but also is where we can have physicians sort of very close with technology, physicians making decisions about technology that comes in and using it the next day and giving us feedback. And so it's in the dermatology practices that we've seen the throughput, the volumes are just so high. And the types of scheduling, like you said, is diverse, it's complex, sometimes, physicians are stretching themselves to try to get patients in, right? So they'll have very complex double book in these times, triple book sometimes in these times, allow this patient to come into my lunch break. Like I'll stay a little after, I'll come a little earlier. You really see physicians stretching themselves to meet the need that is overwhelming. And that's something we is like a core part of our technology and definitely one of the most complicated parts.
No, it's like a perfect use case actually for dermatology. So all the dermatologists listening, go check out it's Simbie.ai, right?
Simbie.ai,
that's where you find it. SIMBIE. We'll put the link below in the show notes as well. It's incredible what you're doing. You're going to be such an asset to our field in dermatology. I can't wait to see where you end up. Maybe hopefully, I know you're in the East Coast now, but maybe we'll get you on the West Coast. I'm sure the programs will be fighting for you when the residency application process starts. But lastly, we always end the podcast with what you're excited about for the future of dermatology. I know we've kind of talked about it a lot with the AI and things coming, but anything specific that you are most excited about?
Yeah, so I think maybe I'll answer this on two levels. One, I'm really excited about innovative approaches we're taking to kind of meet the needs of patients in dermatology. The overwhelming, clear phenomenon here is there's just way more patients and way more demand than there are dermatologists. And patients are waiting. Some of our patients at some of our practices are scheduling so far out. And it's, it's not sustainable. Like we have to meet their needs earlier. So I'm really excited about, asynchronous care tools that are enabling patients to get seen earlier for needs that can be met async. Actually, shout out to my good friend Neil Jareth, who has made a startup called DermFlow to this end that's doing great work. And then shout out to Derm GPT to your work. I think that these tools are sort of the future of dermatology. And then I'll say maybe on a higher level, I'm really excited about in dermatology and beyond, how we generate a future that actually builds physician advocacy for each other, for ourselves, and leadership across industries into training. I think, to your point, my recent LinkedIn post was on this because I had sort of a deep conversation with a friend on it. But I think if we are serious as a field about, for example, advocacy, I find it quite jarring. And I know sometimes we're made to feel like we're not supposed to talk about, reimbursement or salary, having salaries as physicians. I think that's quite crazy, right? We are a professional field. And if we want the field to exist, to continue to exist, we have to think about how people are treated, and compensation is part of how you treat people. And in a setting, for example, in dermatology and medicine, where you have reimbursement rates falling in the setting of inflation, and then we wonder why there's physician burnout. It's just not financially feasible to continue running practices if we have that. But what we need, and on a technology and sort of a business lens, if we're serious about making those changes, we need doctors in those rooms, in the boardrooms, in the halls of Congress, in, legal kind of entities. How do we get there? We need to create opportunities in our training. I think medical students and residents should have opportunities to gain experience in outside industry. We should probably create alternate and more innovative residency sort of schedules and tracks that enable those types of things, because we can't sort of say we want interdisciplinary physician leaders and then not do the work that lets them do that. So that's sort of something I think is really in the future and upcoming, and more people care about this. So I'm excited to see physicians in every industry at the head making decisions that put patients and physicians first.
Yeah, absolutely. And I think, these have been problems that have been building up for some time, but now is the pressure cooker stage where it really is unsustainable. So it's almost like you can't not fix these problems now.
Exactly.
So it's amazing that you're spearheading so much of this. I could just imagine a future where you are leading an incubator and you have lots of physicians, under you, learning from you and doing, all the things that you're doing now. So but thank you for sharing your story. I can't wait to I still need to sit down for a full demo of Simbie AI because it sounds amazing. And I mean, you've explained it to me and I love all the features, but I'd love to just get hands-on with it and play around with it more because it's solving so many, really critical point of care issues. But thank you so much for joining again. You'll have to keep us posted with how the residency application cycle goes.
Definitely
and,
will.
We can check in over time and you let us know how everything's going.
That sounds amazing. Thanks so much, Dr. Kamangar. And I mean, I told you this when we first met, but like your leadership with not only this podcast, but DermGPT, but also just being sort of outspoken advocate for physicians in entrepreneurship, in innovation, it makes a massive difference. When I first heard you speak, it was actually one of the early times that I, was questioning, am I doing the right thing? I'm taking a windy path, an unconventional path. And it's kind of leaders forging that path that make you feel like, okay, if I feel passionately about something and if it's coming from my heart and it's coming from a place of authenticity, even if it's unconventional or maybe not what people are used to, let me push it forward. And your leadership has really been really important for me personally. So I appreciate you and I appreciate this space.
Oh my gosh. Well, thank you. Thank you for that as well. And I'm so excited to see all the amazing things that you're doing.
Thank you.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.